Welcome to ThinkSurgery. In urology, we often associate kidney stones with the dramatic, acute pain of renal colic. But the Staghorn Calculus presents a dangerous paradox. It is often the largest stone a patient can have, yet it causes the least amount of acute pain. This silence is deceptive. While the patient remains asymptomatic, the kidney is undergoing a slow, progressive destruction. In this video, we will dissect the pathophysiology of renal damage caused by Staghorn calculi. It is imperative to understand the natural history of an untreated Staghorn calculus. The prognosis is poor, with studies suggesting a potential loss of up to 50% of renal function within just 2 years. This renal deterioration is not driven by a single insult. Rather, the pathophysiology is multifactorial. We identify 4 distinct, synergistic mechanisms responsible for this damage: obstruction, infection, inflammation, and hyperfiltration. Let us now examine the specific role of each factor in detail. Let's turn our attention to the specific pathophysiology of obstruction in the context of Staghorn calculi. We often term this the hydrostatic injury. To understand this, you must first contrast it with the clinical presentation of small ureteral stones. When you have a small stone passing down the ureter, the patient presents with acute colic. It is dramatic and immediately symptomatic. However, Staghorn calculi are deceptive. They often present with an insidious chronic obstruction. The patient may not be writhing in pain, but the damage occurring internally is profound. So how does this injury occur? Mechanically, the stone acts as a cast. It fills the renal pelvis and extends into the calyces, effectively creating a mold of the collecting system. This structural configuration creates a functional obstruction. It blocks the flow of urine not just at the ureteropelvic junction, but crucially at the infundibula, the necks of the calyces. This compartmentalizes the kidney and prevents adequate drainage. Once this obstruction is established, we see a specific cascade of pathophysiological events. First, we have the pressure dynamic. The obstruction causes significant back pressure within the collecting system. As intrarenal pressure rises, the system attempts to decompress itself. This leads to pyelolymphatic and pyelovenous backflow, where urine is forced retrograde into the lymphatic and venous circulation. Second, we have the vascular compromise. This is a critical concept. The kidney is an encapsulated organ. As the pressure inside the collecting system rises, it exerts a mechanical compressive force on the renal parenchyma. This compresses the intrarenal vasculature, specifically the arcuate vessels. The direct result is a reduction in renal blood flow and subsequent renal ischemia. Finally, we see the histological and structural outcome. This chronic ischemia is what destroys the kidney. At the cellular level, we observe tubular atrophy and glomerulosclerosis. Macroscopically, on imaging or gross pathology, this manifests as cortical thinning. Therefore, when you look at a Staghorn calculus, remember, the damage is not just from the physical presence of the stone. It is driven by hydrostatic pressure causing ischemia, leading to permanent nephron loss. This is why early intervention is critical, even in the absence of acute pain. When you identify a Staghorn stone, you're looking at a specific infectious process. These are almost exclusively infection stones, composed of struvite, magnesium ammonium phosphate, and calcium carbonate apatite. Unlike other calculi, these do not form in sterile urine. They are driven by urease-producing bacteria, most commonly Proteus, but also Klebsiella, Pseudomonas, and Staphylococcus species. To understand how these stones grow so rapidly, we must look at the biochemistry. It starts with the bacterial enzyme urease. These bacteria split urinary urea into ammonia and carbon dioxide. This is the turning point. The ammonia hydrolyzes into ammonium. This reaction consumes hydrogen ions, causing a dramatic shift in urinary pH. We are talking about an alkaline environment with a pH consistently rising above 7.2. In this alkaline state, the solubility of phosphate compounds plummets. This forces the precipitation of magnesium ammonium phosphate, struvite, and calcium carbonate apatite. These minerals crystallize quickly, filling the renal pelvis and calyces to form that characteristic Staghorn cast. Now, why is medical management often insufficient? The answer lies in biofilm formation. These bacteria are not just floating in the urine, they live within a mucopolysaccharide biofilm matrix deep inside the stone's interstices. Think of the stone as a sanctuary. Because the bacteria are embedded within the mineral matrix, antibiotics cannot penetrate effectively to reach them. You might sterilize the urine culture, but the core of the stone remains a bacterial reservoir. The consequence of this cycle is recurrent, recalcitrant infection. The stone acts as a constant nidus for pyelonephritis and urosepsis. Over time, this chronic parenchymal infection leads to irreversible damage. We've established how infection drives stone formation. Now let's look at the consequences of leaving that pathology unchecked. When you have persistent mechanical irritation combined with chronic infection, the body mounts an aggressive inflammatory response. This can lead to two critical diagnoses you need to know for your exams and clinical practice. First is xanthogranulomatous pyelonephritis, or XGP. XGP is a severe chronic inflammatory disorder. Essentially, the renal parenchyma is destroyed and replaced by lipid-laden macrophages, what we call foam cells. Clinically, this is a dangerous mimic because the granulomatous reaction often extends into the perinephric fat and invades adjacent structures like the psoas muscle or colon. It can easily be mistaken for a renal mass or malignancy. For your exams, the key radiological feature to remember is the bare paw sign on CT. This appearance results from dilated calyces contrasting against the thinned, destroyed parenchyma, resembling the print of a bear's paw. The second major sequela is squamous cell carcinoma, SCC. This is a direct result of chronic mechanical trauma. The stone constantly irritates the urothelium, inducing a protective change known as squamous metaplasia or leukoplakia. Over many years, this metaplasia can progress to frank carcinoma. The prognosis here is notoriously poor. Finally, we must address a critical concept for your exams and your long-term patient management: maladaptive compensation or hyperfiltration injury. This mechanism explains a common clinical paradox. Why does renal function continue to decline even after the stone has been successfully removed? The process begins with the reduced nephron mass. As the Staghorn calculus destroys the renal parenchyma through obstruction and infection, the absolute number of functioning nephrons drops. This triggers a hemodynamic response explained by Brenner's hypothesis. To maintain the overall glomerular filtration rate, the remaining healthy nephrons must compensate. They undergo hypertrophy, and the afferent arterioles vasodilate to increase plasma flow. This results in intraglomerular hypertension and a dramatic increase in the single nephron GFR. While this is adaptive in the short term, chronically, this high pressure is destructive. It places mechanical shear stress on the glomerular capillaries and podocytes. Structurally, this damage leads to proteinuria, mesangial expansion, and eventually the histological pattern of secondary focal segmental glomerulosclerosis. Clinically, this creates a vicious cycle. The remaining nephrons essentially burn out from overwork. This drives the progression toward end-stage renal disease independently of the original stone pathology. This underscores why early intervention is vital, to preserve enough nephron mass to prevent this hyperfiltration cascade from ever beginning. And that concludes the pathophysiology behind these complex stones. If you learned something new today, please hit the like button. It really helps the channel. Make sure you're subscribed so you don't miss the next video. Thanks for watching, and I'll see you in the next one.